Device Update 2021, and we have the masters speaking on cardiac devices in next 6 hours. And I hope it will be extremely educating and a learning session for all the participants, including all of us. So it will be an interactive session. So without wasting time, let's get started. So I invite the chairperson of the first session, Dr. Devabrata Rai, to take on with the further proceedings. And the first speaker is Dr. Sanjeev Mukherjee. Devabrata sir.
Yeah, thank you, Dilip. So it has been a wonderful initiative on part of Dr. Dilip Kumar to organize such scientific seminars. And without wasting any time, I would request Dr. Sanjeev Mukherjee. You all know Dr. Sanjeev Mukherjee doesn't need any introduction. He is a well-known electrophysiologist, senior cardiologist attached with Medica Hospital. And I invite Sanjeev to start his presentation on abnormal venous connections, which will be relevant for pacemaker or other device implantation. And I can promise, as usual, it would be an excellent academic feast for you all. Sanjeev, up to you.
Thank you, sir. I will.
Sorry to interrupt. One more thing I want to tell. We have got 24 topics today. So we have to be having a 10-minute session with 5 minutes of discussion. So we will have to stick with the time. And with this, we can start. So Sanjeev, over to you.
Yeah, sure. So I will be quick. And in the next 10 minutes, I'll be on my talk. So respected chairpersons, my dear friends, good evening. I thank Boston, Abbott, and Medtronic for organizing this. So in the next 10 minutes, this is the topic. I apologize for taking liberty to cut short my topic. I have taken off some part of the topic. The topic now is abnormal anatomy and associated challenges in pacing. I'll discuss quickly a few cases as we had planned. So starting with my first case, this was a 50-year-old lady who was referred to us with the intermittent symptomatic 2:1 AV block. Her echo showed, a baseline echo showed dilated coronary sinus. So we expected persistent left SVC. And therefore, the plan was very clear that we will go and put the device on the right side. And so went ahead and before draping, we took a right venogram. And this is what we got. The right, there was absent right superior vena cava. The right brachiocephalic was connecting straight with the left brachiocephalic, and as expected, there was a left persistent SVC which drained into coronary sinus. Now, so obviously we did define the anatomy better by a left venogram, and it was well seen. So options were 3. We could have asked the patient to go for an IVC approach where we put the device on the pulse generator on the anterior abdominal wall that we normally do with all post-Glenn. Micra was an option, and also epicardial pacemaker. So all that was discussed, but obviously patient's relative wished for device from the LSVC as we discussed with them. Now in these cases, just for relevance, we must remember that any complication will not be tolerated well, because here the entire venous upper system venous drainage is going through the LSVC. So we should be quite delicate in our handling of wires and sheaths. So we took a thermoglide wire and were able to cross into the RA, and we took our sheath down. Remember, in these cases of LSVC, getting your RV lead is most important, because that is what is a bit difficult. So we were able to get somewhere around the septal part, infratricuspid, that region, we were able to get our lead, which was more stable. And the right atrial lead was not very difficult, and it was done in a standard way. So the RV lead is something that we need to know and discuss. How do we put the RV lead? Remember, the coronary sinus os, is very close to the tricuspid inlet, and therefore your wire, whenever you'll try to push your lead, it will get deflected on the RA wall. That is what will always happen. So what you do is you take your stylet and you make the stylet, you give a curve, what we call as Bond's curve, a large C curve you make, and make a small secondary curve on the distal end. And with that long curve, you will be able to get into the tricuspid valve. And once you are in, push pull back your stellate and allow the lead to fall in, and then you can take it to the apex or septal part wherever you are planning to put the lead. Now that is the only challenge that will happen in these cases of LSVC when you are putting your RV lead. And so once your RV lead is in, the LA lead normally in a standard way will go and fall in the lateral wall. If you want to get it into the appendage, you will have to do a slight clockwise torque. So you will get the RA lead will not be very difficult in these cases. If we discuss of epidemiology, it's this particular case. I mean, normally LSVC will have, it's about 0.5, but isolated LSVC is very, very rare. It's about 0.07 to 0.13% in general population. And it is basically because of failure to regression of the left anterior cardinal vein, as we all know. And most of the time it will be draining through the CS into RA. Rarely will have an LA drainage where the patient will present with cyanosis. So it will not be a great difficult. I think in today's world, LSVC casing is more or less standard accepted norm, and we should be able to handle it. The only thing is it presents without telling us. So that is the time we should be mentally ready. Next case, a 79-year-old lady, known case of chronic obstructive pulmonary disease, a lean thin lady, BMI of 20, presented with symptoms of complete heart block. She underwent a dual chamber permanent pacemaker, and 3 hours later, she started having central chest pain and an unwell feeling. So obviously an X-ray was done, and this is what we noticed on the X-ray. As you can see very clearly, what was noticed on the X-ray was that she had a pneumothorax more on the left and also a small on the right. So she had bilateral pneumothorax. And why I brought in this case is because there are certain high-risk features when we take patients for pacing, which is more or less a very standard and safe procedure. But if a patient, female gender, BMI less than 20, elderly more than 80, patients who have got chronic obstructive lung disease with inflated lungs, somebody who has already shown a bullous emphysema, patients on blood thinners, emergency procedures, restless patients, these are all very high-risk subsets. And in these cases, when we go ahead with a subclavian or axillary puncture, we must maintain some caution, try to do venography, use fluoroscopy guidance, and if cephalic cut down can be done, then that's definitely a very good option. The most interesting thing in this case was bilateral pneumothorax. Now, left we can explain probably while the subclavian puncture was attempted, it would have caused trauma to the pleura and would have caused the left pneumothorax. This expanded, she was given an ICD. But right-sided pneumothorax, which the contralateral pneumothorax was probably because of right atrial lead. Now, the possible mechanisms are one, many a times the right atrial lead will perforate the RA wall, which is very, very thin. And very rarely, the entire Seldinger set, when we take down, can cause injury to the SVC in its extra, in the extrapericardial part of SVC, you can sometimes cause injury and cause these kind of contralateral pneumothorax. CT scan is the best way to diagnose, confirm the findings. Most of the time, you won't have to do anything. They resolve, they heal spontaneously, and nothing else is required. But this is something which should be kept in mind in such cases. The last case, a 65-year-old male, known diabetic and hypertensive, who presented to us with history of presyncope and exertional dyspnea. And the Holter showed very, very long pauses, which correlated with his symptoms. So more of a symptomatic sick sinus individual. And his echo showed a situs inversus dextrocardia with no other structural heart disease. So it was a standard mirror image kind of dextrocardia, but there was nothing else other than that, no shunt lesions, nothing else. His coronary angiogram did not show any critical stenosis and showed a span for a pacemaker in a conventional way. Now, we thought we'll also do some amount of basic EP, and so we took our catheters up, but unfortunately we were not able to move our catheters. So I have put on the right the image, and this is probably what the anatomy was. So what we did was to define the anatomy well. We took a Terumo wire and defined the anatomy. So probably he had an inferior vena cava, which was probably double inferior vena cava. There was discontinuation of IVC, and it was an azygous continuation, which went up and connected with the right brachiocephalic, and that is how the anatomy was. So, so the decision was obviously, a device has to be put. So dextrocardia, we all know, means their entire cardiac mass is in the right hemithorax, and this patient had a mirror image, normal vestibular arrangement, and without much of an intracardiac defects, and statistically they have about 23 to 70% of patients may have defects. Now, in this case, we decided to go from right side because there is a small case registry from our very own Jayadeva Institute, which was published in Europace in 2014, where they have implanted pacemakers all from the right side. So based on their experience, we went ahead with the right-sided implant. And I was lucky in this case because TPI was not required. He was more of a 6 sinus. But if you have to put a TPI, you need to have a barred lead, which is 110 centimeter balloon tipped, a long lead, which you can take and manipulate into the RV in these kind of anatomies. So obviously, any such kind of an anatomy, you need to define the anatomy well. We have shown with the Termo wire, and we took 2 check angiograms, kind of venograms, and it more or less was what we have seen before itself. So this was from the brachiocephalic, and this is what we have seen with the Termo wire. So the anatomy was more or less clear. So we went ahead with the right-sided approach, and we did not have much of a difficulty while manipulating it. Only thing is that, remember, when you put your RV lead, make sure that in RAO 40, it should look towards the spine, and in LAO 30, it should look towards the apex. Just reverse to what we normally do in our other cases. And right atrial lead position is confirmed by to and fro movement of the lead tip and by the anterior position of the lead in LAO view. So this is what we got, and the leads parameters were pretty well, and we accepted that, and the patient is doing well. So I think I'll end here. Thank you.
Yeah, Sanjeev, as usual, excellent exposition of some clinical cases. So I think we have another 5 minutes time. So any quick comment or any question from anyone in the audience?
Sanjeev, I have a comment on that. We shouldn't be that harsh on an operator that he caused cracks left and also right through right atrial lead. So there can be one possibility as well. That is, once you do a hemothorax on the left side, so the left lung function goes down, right function goes up, and if the patient has a bulla in the right, so it can also rupture. So that could be another explanation of a bilateral pneumothorax in a patient with left-sided procedure. So
yeah, I agree. Possible. Yeah, definitely. So.
Sanjeev, yes, in your registry, you are taking up the dextrocardia cases with the for the pacemaker with the right-sided approach. Is there any particular reason for choosing the right side for the dextrocardia?
Right, sir. No, I was quoting a paper from Jayadeva, sir. They have published a case series of 6 cases in Europace in 2014.
Okay.
And in that, they have implanted all the devices from right side, though no logic was given. But that being an electrophysiology center, we all electrophysiologists like putting from the left, but they have put everything from right. So I just followed their approach because I didn't want to try something new here. That is what I said. So I followed the right. But I don't think there is any reason for it. Maybe from the left, you might require sometimes a longer lead, probably, because the course, if you look like it has got some tortuosities, and probably that might be the reason.
Another question is sometime with the dextrocardia, if you reverse the image in the intensifier, then possibly you can do the same thing like in the levocardia. So
true.
Do you agree with that?
Yeah. So that is how we do all the angiograms. In this case, also the angiogram was done similarly. But the interesting thing was here discontinuation of the IVC, which I was not expecting. The IVC was interrupted, and there was a azygous continuation. So that the TPI lead didn't go, and there the whole kind of confusion started. So what I wanted to convey was that these kind of things can happen in a patient where you're not expecting such things. And there, I think a mental preparation is what we should have. That's the only thing. So once I was not able to take my TPI up, then the whole thinking process started, how and what, whether I should come from left, because normally I put my devices from left. So that is the thing. But I agree to your point. If you reverse, yes, it will be like a normal case.
Yeah, Sanjeev,
yes,
I know you had very less time for showing your cases, but any quick comment on your cephaloaxillary confluence you faced any in your experience?
Yeah, the first case in the persistent LSDC, the initial wire
for the fellows who are attending this program, right, how to overcome this. Just a quick comment.
True. So in the first case, LSVC, I would say yes, there was initial resistance, and that is why a Teremo wire was taken. And I had some slight resistance in the movement. And that is why I said, please maintain caution, because that is the only venous confluence you have. Your right SVC is also not there. So go gently, and normally a Teremo wire makes its way. Once it is done, then you take down your sheet, which might show some resistance, but most of the time you'll be able to take it down. So not much of a problem, but there was some initial resistance. That's it, yes.
Dr. Anup Gupta was giving some comment.
Case, like, means normally we don't switch over to right side if it is a left persistent left SVC. Probably we have done more than 20-25 cases now. In fact, we have put a lot of CRTDs and CRTPs also from left SVC. So things like, you have to make a curve in your sheath, and your regular wire, that should be fine, because when you are dealing with the left SVC is so much so dilated. In fact, you can put 7, 8, 9, 10 leads, whatever amount of lead you really want to put. The other comment, Dr. Das has already said, like, you can make a mirror image for dextrocardia, things become very easy. And again, if you're doing for a dextrocardiacitis versus choosing a site right versus left, it's all up to the operator, but it doesn't really matter from which side you really want to put. And venogram upfront is always good for axillary vein puncture. There's no question about it.
True.
Okay. Sanjeev, thank you very much for your excellent presentation, and over to you, Dilip.
Thank you, sir. And it was a great opening of the day. And the second session is by Dr. Anup Gupta, difficult decisions in AICD cases. We have Dr. Arup Das Viswas as the chairperson and Dr. Ashish Haldar as moderator. So over to Dr. Ashish and Dr. Arup Das Viswas. Dr. Das Viswas, sir? We can't hear you.
I think he is there, sir.
He is on mute. So Ashish, you can...
Okay. Good afternoon, everyone. We are just about to begin another session after an excellent talk of Dr. Sanjeev S. Mukherjee. So we have with us two eminent cardiologists of India, Professor Arup Das Viswas to chair the session, and Dr. Anup Gupta, who will be talking on difficult decisions in AICD cases. So over to you, sir.
Yeah, thank you very much. And thank you, Dr. Dilip, for inviting me. Am I audible?
Yeah.
Yes, sir. You're perfectly audible.
Okay. So in fact, I was wondering, like, what should I show for a difficult decision in AICD cases? And when Dr. Dilip said, like, most of the audience is a cardiologist, fellow and cardiologist. So I think it should be quite appropriate, because nowadays what I'm going to show is, like, it's a forgotten thing inside the cath lab, and we don't often perform the same thing. So this was a very young guy, 30 years, had an episode of VF, and who underwent CRT-D implantation for heart failure, and as well as ventricular tachyarrhythmia as a bridge therapy, because the family was counseled, like, it's a very sick heart, probably he will down the line, he will require a transplant. But for the transplant to survive, we wanted to give him a CRT-D implant. The LV ejection fraction was very, very less, 10-15%. In fact, I remember, like, when he was admitted, it took almost 3-4 days to make him settle down so that he can undergo the procedure. And since he had 2-3 episodes of sudden cardiac arrest, so he was on immunoderm for last 3 months. So the implant was pretty good. And this is what the topic, like, which I'm going to focus. So defibrillation threshold testing was not performed in view of good lead impedance and good lead parameters at the time of implant. And to our surprise, the patient, though the LV was quite dilated, he improved remarkably after CRTD. And from NYHA class 4, he came to class 2. And LV function also improves remarkably at 35%. And he came for a follow-up. And, after 2 days, like, after 3 months, when he came for a follow-up, after 2 days, I got a call, like, he has become unresponsive at home. So he had a sudden cardiac death after 3 months at home. So this was the initial implant. And if you see the lead position, pretty good. In fact, you can make out, like, the heart is too big, very big heart. And that is the reason, the family was counseled, like, probably he's going to require a transplant for sure in future. So now the thing is, like, why this thing happened and what is exactly it is. So, if you go through all the studies, and which has been shown, like 32% of cardiac death seen in ICD could be due to sudden cardiac arrest. So all the studies, like, if you take EVIT, CASH, SIDS, made it 1, CABG patch, made it 2, definite, dynamite, ERSCA-DEFT. whether it is for primary or for secondary prevention. If you see the percentage of sudden cardiac death is almost like 30%. So 31.9% if you see here. So the combined percentage is almost 32% of sudden cardiac arrest. So this is one thing which really bothers, and means I'm quite sure most of the cardiologists who are attending, they must have heard about the same thing, after giving an ICD also patient had a sudden death. And to explain the family, sometimes it becomes very, very difficult for us to explain what exactly has happened and why it happened. So sudden death in spite of ICD therapy, we know if the patient is in storm, 16% of patient, or it could be primary no electrical activity, so pulseless electrical activity, that is almost like 20%. But most common, which are rectifiable thing, is the post-shock pulseless electrical activity, which is almost like 35%, and shock failure, that is again 30%. So these are the two subset, where you really want to work out and see how you can improve the thing, because these are treatable by improving the safety margin. And one of the reason, is patient dying is they remain in VF despite getting many shocks, and then finally it becomes a pulseless electrical activity. So 65% of sudden cardiac death in ICD could be avoided by improving the shock effectiveness, because if you see here 30 and 35%, so almost 2/3 of the patient, you can definitely do that thing. Now retrospectively, we were wondering we should have done, because the factors which really have been associated with high DFTs, low ejection fraction, so it does fit into that thing. In NYHA class, he was class 4, again it fits into that. He was on amiodarone, and we know that amiodarone increases the DFT level, threshold level. So, and he was on amiodarone for more than 3 months, I would say. And again, he had history of ventricular fibrillation also. These are the subset where high DFTs are expected. And in fact, sometimes you perform a DFT during the implant, and it can change over a period of time also. So there are no perfect predictors of high DFT. And I believe me, 90% of time, we are not performing any DFTs nowadays, because the lead parameters, if we are happy with the thing, we are happy with the fluoroscopic imaging of the lead, we don't perform DFT. Many times, if the patient is very sick, we are quite reluctant performing DFT. And in this case, probably that was my mistake, because, I thought that patient is too sick to perform a DFT. I wanted to avoid performing a DFT. So if the scenario is a high DFT, so what are the approaches, what you can do? The most important thing is the RV coil polarity. So if it is positive and the anode thing in the coil, that is very, very important. So it can lower or equal the DFT in 88% of patient. 12% what is not done is probably because of noise. Must be changed in the same modes, and there is no side effect. Again, coming to single coil versus dual coil. So, nowadays preference is always single coil. We don't go for dual coil. The reason is because if the patient has got some kind of infection, or suppose patient need any upgradation, or suppose some lead malfunction, and you want to expand the lead, so single coil is much easier to remove. So that is why, and in this patient, we went for dual coil. The reason was because we knew that it's a big heart, probably will require a dual coil. And that is what we call as a cold can. If you have a high voltage devices, so, you can reduce the DFT by 25%. Again, that's very, very important. So, selecting patient with a big heart, with a severe LV dysfunction, if you can get a high voltage devices, again, make a lot of sense. The other thing is, if you have got a function of programming the pulse width, so certainly you can again reduce the DFT by 40%. This, when I was in US, because the patient used to be like 400 pounds, 350 pounds. So, we used to put a lot of subcutaneous array at the time of implant, suppose the DFT is high. But again, believe me, this is a very tedious job. You need to call a surgeon, and then placing all the 3 arrays in the subcutaneous part took a long time, and sometimes patient used to complain a lot of pain in that thing. The other thing, if it's a high thing, if you have got azagus, it's a blessing in disguise for ICD. So you can put an additional lead in the azagus vein. So, it is a very, very good vector conductor. So, you can reduce the DFT, though it's difficult to implant. But if you have an azagus, you can certainly put a additional lead in the azagus vein. So when we are talking about the RV coil polarity, so all the meta-analysis, it has shown if you have a positive right ventricle, it is almost like 46% is better than the negative polarity. And this is what I said, 88% of time you can optimally get down the DFT level, 12% mostly the statistical noise. And the polarity, the most important thing, polarity should be set at RV and node, and it should never be reversed. That's very important. So coming to single coil versus dual coil, again, if you're putting two coils and you are making the SVC coil on, so you can have from the RV coil to the SVC coil, it could be one vector, or from the RV coil to the can, it could be second two vectors. So if the can is off, then we call it a cold can. And if the can is on and it's a single lead, like, you don't have a SVC coil and you're doing only from RV coil to the can, so, we call it a hot can. So the difference between the two is the defibrillation energy travels to the can in single coil, and in dual coil, it can go either to SVC or as well as to the can. So the studies, what has been shown, and it was done in way back in 1999, that time, there were a lot of things coming, whether you really want to have a cold can or not. So what it showed, like, hot can was better than the cold on the right side implant, only on the right side implant. So the defibrillation threshold was lesser for the hot can in comparison to the cold can. And cold can was worse, 27% worse than the hot can. The other important thing, if suppose you are implanting ICD from the right side for any reason, like, suppose you have got a left persistent LFCC and you don't want to put a ICD lead from the left SVC, or you have got an occluded vein, or you have got an infection on the left side, always perform a DFT from the right side, because the DFT from the right sides are 50% higher in comparison to the left side. So if you see here, the DFT 17 versus 11 in the study by Friedman et al. So right side always perform DFT because the DFTs are high, and hot cans can be better than cold on the right side. So this is what I was saying, like, putting a subcutaneous array, and this is how it looks. So, means you have got a device, so you have a connection for the subacute array. So these subacute arrays should be separated apart, and they give, additional safety for the shock. So this is how it looks in a PA view, and this is how it looks in a lateral view. The other thing, what I said, like the previous speaker's case, where there was a persistent aegis, if you have a big heart and you have got an aegis vein, so in that case, you can put an additional lead in the aegis vein, and the aegis vein are always posterior, always posterior. So, the best view to see it on the lateral aspect. So inside the cath lab, you do a lateral aspect, see whether you have placed the lead very well in the aegis or not, and then you can test the threshold level there. Certain patient in which that the transvenous threshold is pretty high and patient is undergoing for surgery, this has become very obsolete, but the defibrillation patches, the epicardial patches are still available. You can order those things. These patches are sewn directly to the outside of the heart, placed maximally across the heart mass. So one is in the RV anteriorly, the other one is laterally to the posterior part of the left ventricle, and these are made of a titanium mesh, and the Dacron, it reinforces the rubber. So this is how it looks. If you see the patches, this is how it looks. And you can put the patch across anterior and posterior in the RV and LV. And there's a schematic diagram you can make out. You can see here, this is the RV and this is the LV one. And again, the fluoroscopy or the X-ray shows the patch like this. So epicardial system, the patient who has got infection, this is the only indication nowadays. If the patient has got an infection both sides, and his patient is not affording the subacute ICD, because now the subacute ICD has taken care of this thing. So, the epicardial system and the patches have become very, very less. Or else the patient is undergoing a CABG surgery and the patient needs an ICD as a secondary prevention, and you want to put a surgical patch. In that case, you can think about it doing the thing. The other thing, how you can reduce the DFT is biphasic shock and membrane burping response. So this is very important. If you see the shock waveform and the membrane response. So the first phase, it charges the cell membrane. And when the second phase comes, it removes the residual charge on the borderline, and return the cell membrane to the baseline. So the waveform truncation should occur when the cell is most responsive. And here you really want to give the shock. So, it can reduce the DFT level by giving biphasic shock. And what I said, like the newer generator, they have got a programmable pulse width, so it can allow the energy to be delivered more efficiently, matching the waveform. So whatever the waveform, if it is a large waveform, so you can have a pulse width of 4.5. It is short, it can have 2.5. So the shock truncation is there, and you can really help the patient to do that thing. And this is what it showed, like it could be slow conduction, it could be medium, or it could be fast. So it could be slow, so slope is going to be very, very long. It could be medium, that is what you normally see, and it could be fast. And according to that, you set the pulse width Could be 3, could be 3.5, could be 4. And according to that, you set it so that the depolarization time matches the impedance value and the appropriateness of the shock is very, very high. So this guy was, when he came to the hospital, he was in incessant VT at the time of admission, which was reverted by external DC shock. The hemodynamics improved immediately, and patient, even the cardiac function, everything was fine. But, by the time you reach hospital in Indian subset, the patient doesn't reach in 10 minutes, 15 minutes, and that's a quite a long time. So he was brain dead after 3 days. The family said, we don't want to continue. And that's how. So conclusion, DFT is a very debatable issue. You really need to, it's a clinical judgment in each cases when you want to perform DFT or not. And most of the time you should find out what are the reversible causes of high DFT and which can be corrected. Most important thing, if the patient is on chronic amiodarone therapy, that is one thing you should think about it. If it is a large heart, always think about putting a high voltage device in those situations. I'll stop here and take your question. Thank you very much.
Thank you, sir, for a great presentation. Any question from any participants?
I think with this devices we can give high voltage, and increasing capacity of delivering high volts, the requirement of arrays and the additional leads are gone. And so as the epicardial, we don't think, and it's a kind of a at this present juncture, maybe it is obsolete. What's your idea? And besides a large heart or maybe a chronic amiodarone therapy, which are other cases where you would like to go for a kind of DFT testing?
See, that is the most important decision when you're implanting in ICD nowadays. Means I would say like 10 years back, 15 years back, when we were implanting ICDs, we were doing DFT in probably each and every cases. Now for less 10 years, because two different schools of theory, like, people say, now you don't need DFT. DFT doesn't help because over a period of time, it keeps on changing. So we don't know. But in my clinical practice, if I'm doing any implant for a secondary prophylaxis, one thing, if the patient NYHA class is high, if heart is big, or patient is on antiarrhythmic medication for a longer time, certainly I do a DFT. Till now, I do all DFTs, because the thing is that, if you do a DFT inside the cath lab and the DFT is high, you can try and rectify the things. The important thing is, if suppose you don't perform a DFT and patient gets an event at home, many times we are not able to make the patient survive. So, you cannot rectify those things. So that is the reason I said it's a very, very debatable thing, very, very debatable thing. I really don't know. Primary prevention, I don't perform any DFTs, because if the lead parameters are fine, I don't perform any, because see, in any case, we are giving an ICD for a primary prevention, but secondary prevention, I do. And what you said, like, array and these things have become absolutely obsolete, because now you've got a subcute ICD implant. So, subcute ICD will solve that problem. And now, fortunately, you have got 40 joules, 41 joules devices. So that again takes care of things.
But I am surprised to hear from you that you are still going in 100% secondary prevention patients are going for DFT. So now there are operators which are, besides the primary, secondary also they are.
Yes, that is what I said. Like, majorities are not doing. I still perform.
Great. Dr. Das Biswas, sir.
So this is Dr. Pandey. I have a small question. So to you, what exactly, in which situation you choose a subcutaneous ICD apart from very young individual will require for the future recurrent replacement of the device? Apart from that, is there any other indication, infection and young individual apart from that?
See, again, like, many times it's a venous anomalies. See, if suppose you have got a venous anomalies, or suppose the patient has got an infection in the prior devices, one thing. And second thing, if you are doing for channelopathies where that you don't require pacing, so probably I would go for subcute ICDs in those patients. I agree with you.
So we have we are running out of time. We are 2 minutes, late already. So we can move on with the next presentation. Thank you, Dr. Gupta.
Thank you.
For the terrific presentation. So Dr. R.D. Yadav will join in next 10-15 minutes. So we have Anunay speaking now on EGMs and troubleshooting in AICD. And to chair this session, we have Dr. Raja Nag and moderator is Dr. Smith Srivastava. I request Dr. M.K. Das to chair this particular session as well, sir.
Okay. Is Dr. Raja Nag is the chairperson? Is he present here?
He was there, I think. Yeah.
Okay. I think let us start the session right now. Dr. Sanjeev Kathuria, you start your proceeding with EGMs and troubleshooting in pacemaker.
Anunay Gupta, sir. Anunay Gupta. Anunay is a...
Yeah, sir, I am there, sir. Are you able to hear me,
okay,
sir?
Anunay Gupta. Okay.
Dilip, sir, I am audible now?
Yes, yes. Go ahead.
First of all, I would like to thank Dr. Dilip for inviting me for the talk. And at the first instance, I would like to say that to cover troubleshooting in ICD in 10 to 15 minutes is extremely difficult. But still, I will try to do justice and try to finish my talk in 10 to 15 minutes and discuss few important cases. So first and foremost, we should all know that ICD detects tachycardias imperfectly and they also classify tachycardias imperfectly. So thereafter, there is the importance of stored ICD EGMs. It's extremely important at how we interpret them because they help us in detecting SVTs, VT, and VF episodes. And the annotation which is present there is also of extreme importance. So a few points about primary and secondary prevention. We all know that in primary, we program our device in two zones. With 2 zones of VT and VF, while in secondary we are programming 3 zones, VT1, VT2. VT1 is less than 20 beats per minute compared to the clinical VT, and VT2 and followed by VF zone of more than 20 beats per minute. First of all, we have to understand what is the ICD see. So it depends which type of ICD we are implanting, but for all the standard ICDs, there are 2 EGMs. One is the far field EGMs, which is between the ICD can and the RV coil. And this EGM is predominantly used for the morphology analysis. Will help in differentiating SVTs and VTs, and the second one is the near field, which is the sensing EGMs, and which is between the RP tip and the ring, and is used being sensed on the marker channel. As if there is a atrial lead, you will see AS also, and there is a VS. If there is a dual coil ICD, if there is a proximal coil, and then with the ICD we can see at a larger area of the heart, and even it can give us a proper ECG with a proper P wave and QRS. And many times a small T wave also. So whenever a patient comes to us with a shock, first of all, thing which we have to see is the clinical scenario, and then we have to ask for stored EGMs. Then if we found there is a tachyarrhythmia, so it can be either a SVT which has been inappropriately detected as SVT, or if there is a VT-VF which has been appropriate detection. So in that case, what we have to do is stop the arrhythmias. And while if the case in this there is no tachyarrhythmia, so likely due to oversensing we are having patient is receiving inappropriate shocks. So it can be either due to an intracardiac signal and extracardiac signals. So in those cases we have to stop those extracardiac signal or intracardiac signals to happen, and even the device can require repair. So ventricular oversensing in ICD is an important issue, and it can be either cyclical or non-cyclical. Cyclically extracardiac predominant one is the myopotential and EMIs. Myopotentials are physiological and non-physiologicals are lead and connector issues and EMI. Intracardiac non-physiological can be lead failure. While the cyclical ones which we see are usually when there are more than one or more than one oversense events likely due to lead failure. While if it is a one oversensed event per cycle, it can be that due to P wave oversensing or T wave oversensing or R wave double counting. So this schematic diagram making us understand where all the problem can happen. In the lead, it can be either due to a lead fracture or a loose set screw, or if there is presence of air bubble in the header. EMI can interfere both the high frequency far field and near field. And even the intrinsic cardiac events can be missensed as and happen as a noise and lead to oversensing. 3 important oversensing issues which we encounter in our ICDs which lead to inappropriate shocks are diaphragmatic and pectoral myopotentials, and second one is the EMI, and third one is the lead fracture. So myopotential have a classical presentation. They usually present on the near bipolar. If it is from diaphragm, you will predominantly find on them on the RV, and if then pectorals, you can find them on the shock also. So but it's very uncommon to see them on the shock. and their pattern is not a stable one, it's a variable pattern, and even the cycle length is also variable. But we will if we do an interrogation, there will not be any change in the RV lead impedance. Well, in case of EMI, you can see there's a consistent pattern which we are seeing, and it's been seen on RV atrium and also on the shock AGM. And even in this case, the lead impedance will be normal and the cycle length will be significantly variable. The third one which we encounter is a lead problem. Rarely lead problem can lead to a no change in impedance, but in a usual scenario, it leads to a change in impedance. And it is also reproducible if we ask the patient to take a deep breath or push his hands against the wall and make the lead more stressful. So as you can see here, it's not follow a consistent pattern, and there's a different amplitudes and morphology, and the cycle length is also very variable. Lead failure can happen either due to a patient's conductor fracture or even a loose set screw. So they both present in the same way, and it is extremely difficult to identify them on the ECM and will require fluoroscopy and further interrogation. A classical this conductor fracture and lead header connection problem presents as an intermittent problem, intermittent high frequency oversensing, and it can lead to amplified saturation. So which are the classical feature is that amplitude and morphology and frequency is very variable. It makes it non-cyclical, and the intervals are very short. So ranging from 110, 120, 140. So a classical oversensing issue of lead conductor fracture or a loose set screw. With this background knowledge, I will discuss few cases. First of all, this is a case of ICD which was implanted around 4 years ago, and the patient received a shock while he was sitting in the chair. A chest X-ray done in the emergency department was normal. So based on this, what is the most likely diagnosis? There will be a zoom poll in front of you, and I will give, due to lack of time, I will give you around 10 to 15 seconds to answer. So let's see what are the answers. So I will request everyone to answer if they're able to see the poll on their screen.
Please show the ECG. Please fix your slide on the tracing.
Sure. So this is the tracing. You can see here there's the annotated marker channel. This is the far field left, and this is the ventricular near field. This is the shock which has been delivered of 40 joule, and later on again you can see some high frequency signals on the V field. So in this case, the likely diagnosis is lead fracture, as it is happening after 4 years ago. After the 4 years of implantation, it can be related to loose set screw also, but it usually happens for within the hospital stay. And you can see here these are the variable frequency signals of different morphology and amplitude. The cycle length is also very not seen on the far field, only seen on the V channel.
And one very important thing, Ananya, is that they're high amplitude, which
Yes.
is very characteristic of a lead fracture.
Yes.
So they're high amplitude, low frequency. The frequency is not high, but they're very high amplitude.
Yes. Thank you, Dr. Katuria. This is the second case. Here we have to apply our EP knowledge also. So this is a dual chamber ICD. It was implanted 4 years ago, and patient came for routine follow-up, and the patient is doing fine, and he don't even remember that he received a shock or not. So this is the EGM. This is the continuation of the same EGMs. So what is the likely diagnosis? Options are atrial tachycardia, AVNRT, AVRT, and VT, and then I will focus on annotated EGMs. These are the 1, 2, and 3, which will help you in diagnosing. So if we can have the zoom poll, and then you can see this. So the options are atrial tachycardia, AVNRT, and VT. And we have to focus here on this ventricular EGM, and then this second one, and then what are this T. So this is a episode of ventricular tachycardia, which was non-sustained and with 1:1 VA conduction. But we see here that there is a ventricular sense event happening. It's likely a ventricular premature beat, which is happening very early, at around 47 millisecond after the sense, unlikely to be a normally conducted beat. And device basically compares it with the normal beat, which is, you can see here, this beat, which a normal V sense is different from this one. And then again, a ventricular premature beats happen and the tachycardia starts. And this is also different from this beat, and this is a sinus beat. And then there is a morphology match, which says that this is tachycardia is not matching the sinus template and has been diagnosed as a ventricular tachycardia. Patient received an appropriate ATP and the tachycardia terminated. So all ICD works on have a morphology algorithm. So it's every manufacturer has a different way to do it, and but there's some basic knowledge which is same in everyone. So what happens that in the sinus EGM is made for template and it used with the can and the RV coil rather than the near field one, and then it is being stored in the device. And later on, what we see when a patient develops tachycardia, there is a threshold of 70%. So if it is a match of more than 70%, it's diagnosed as a sinus beat or supraventricular tachycardia. Whenever the threshold is less than 70%, is diagnosed as a ventricular tachycardia. Morphology algorithm is not 100% safe, and there are many times when we encounter that the morphology discriminator fail. What happens that it's due to an accurate template, because as we can see that patient sinus beats and it can vary over the time of the from the date of implantation. So that can happen. Even alignment errors can happen because if they are not directly aligned with the time. And if there are EGM truncation, the EGMs are clipped, so they will vary between the sinus and the tachycardia beat. And one of the important condition when the morphology discriminator will fail when the patient develops rate-related aberrancy, because in that case, the template will be exclusively different from the sinus template, and patient will receive an inappropriate shock. And as I've discussed about the interfering potentials, they can also lead to a problem in the matching. A few examples here, as you can see here, this is a sinus beat, which is being matched as 88, 91%. But if we don't align the time marker correctly, suddenly it becomes a 0%, while even the beat is EVGMs are absolutely similar. Similarly, some interfering potential can lead to a poor matching of 34%. And if the EGM is truncated, so it will not match properly and will be misclassified as a ventricular event.
Anna, you're a little quick.
Yeah, could you go to the last slide and just have one or two comments from the audience, please?
So this is a...
you can show these cases, I think 2 cases. Yeah.
Yes. So this is a EGM of an event, the classical dot plot, where you can see that there's a tram track appearance, and it's a classical of T-wave oversensing. So here you can see that the T-wave which are so tall are being sensed on the marker and also as BF, PF, PF, and the patient repeats multiple inappropriate shocks. And but this not classical of T-wave oversensing. It can even happen with R-wave double counting. And if it is C to 2 block, so then there will be a tram track appearance, and even the R field oversensing can lead to a tram track appearance. So the device, this can be treated by as I've told, that the auto adjusting of sensitivity which happens in the device, you can delay the decay, and even the threshold start rate can be increased. And in this case, you can see here, this T wave is not oversensed in V tip to high voltage B. It's only being sensed on V tip to V ring. So if we change from a dedicated true bipolar to integrated bipolar, we can avoid the T wave oversensing. A patient receives a shock immediately implantation after an ICD in ICU. And you can see there are multiple high frequency signals on the RV tip and RV ring, and the duration is decreasing over the time when the patient receives shock. If it happened immediately after the implantation, the most common cause is air in the header. So what happens if we don't put our don't remove the air properly while inserting the device lead tip? So air can get entrapped, and over the time it gets released and leads to interference between the signals and lead to high frequency signal and inappropriate shock. Nothing has to be done for this, and even within 48 hours, this air gets released, and you can just off that therapy in ICD, and within 48 hours, this air will get released and nothing can be done. Nothing to be done for that. Thank you.
Yes, 1 or 2 comments. Dilip?
Yeah, I think with the newer devices, this air in pocket and air in header is almost again an obsolete thing. So this snugly fit devices are there, and it takes care that extra air is not there. And with the design of the pacemakers, air in pocket is out of question these days. But it is important to know this problem can happen.
Yeah, I think Dr. Gupta has beautifully presented the various cases with much intricacies, and EGM knowledge is very, very important to come to the real diagnosis and take the appropriate action.
Excellent presentation, Anurag.
Yes. Should we conclude?
Yes, sir.
Thank you very much.
So we will move on with the next presentation. Dr. R.D. Yadav will be presenting on difficult CS anatomy and bailout in CRTs. And the chairperson is Dr. M.K. Das, moderator is Dr. Somya Patra. So Dr. Das, sir, again, over to you.
R.D. Yadav is a very good friend of ours, and he is an excellent operator, electrophysiologist, and a very strong speaker. So over to Dr. R.D. Yadav, please.
Thank you for the invitation. Sorry for the delay, as I was delayed because I went to do one CRT-D implantation. So this technique, tips and tricks, what I will say is all mine, how I use it. So technical challenges encounter LV lead placement, case-based discussion basically. So how I do LV lead implantation, always puncture extrathoracically or axially vein for LV lead. Always use sleeve-table braided seat. I don't use P-level seat anymore. I think last 20 years I don't use it. Enter into CS by using prefixed curved decapolar or TPI lead of Sendute, as this helps entering in CS, as due to LA and LV largeness, CS make a hockey stick like angle. 90% of time, no need to do selective CS angiography, but use levo phase of the left cornea artery angio in LAO 45 degree in AP caudal view. AP caudal and LAO view is my working view, and sometimes AP view, because in AP caudal the radiation to the doctor is less. If down looking origin of the lateral vein, then the posterolateral vein, then use 4 French or 5 French IMA angiocatheter to engage the vein, and use whisper extra support wire or similar plastic coated wire. Sometimes might need Grand Slam or Ironman wire or Buddy wire. 90 or 130 degree sub-select should be used in difficult angulation and tortuous vessel. If stenosed vein, then do balloon angioplasty with 3 mm NC balloon or cutting balloon. ICD lead I put first, then LV lead and RA lead later on to keep, if required. RA lead sheath can be used for the snaring and holding the wire orthodromically or antidromically. So RA lead I put later on, but RV lead I put initially. So let's how to go next. Sorry, next. Okay, so this case 1 is 45-year-old male, diagnosed case of DCM, normal coronary, ejection fraction 25%, means standard indication for CRT-D implantation. And so this is the anatomy. We see the levo phase of the CES, which is clearly seen. There is a lot of tortuosity. So what I do is, this is LAO view where it hooked 45 degree. It showed this is the vein, very tortuous vein, how to enter into this vein. This is LV, which is severely hypokinetic and severe LV systolic dysfunction. Went there, and then it could not. So this is the vein which we are going to target, very tortuous vein. So we took the wire, lead didn't went, so took the subslack. Even then subslack it was not going, so there was a tight stenosis which the angioplasty was done, and thereafter we put the subslack, and then lead goes easily, and we deliver the CRT-D without any problem. So this is second case. This is interesting case, again indication for CRT-D. We put the because there is no connection of the SVC with the right innominate vein, so there is a connection. LSVC, patent LSVC is there. So the major problem is to go into the RV of the ICD lead. So we took the long sheath of the ICD lead, and with that lead we put the put the RV lead into the septum, and then the atrial lead is very easy. Atrial lead is not a problem. Then there is a LV lead. We put a vein here on the from the LSVC to the coronary sinus, and from there the branch is there. We put the, and this is the way we put the CRTD in persistent LSVC. So it's not a big issue. You can do it. And nowadays, if you fail, you can do even left bundle pacing or his bundle pacing, depending on your need. This is how the most difficulty in this case is the placement of the RV lead, where I use a long seat. So if you see the patent LSVC is rare congenital anomaly, 0.5%, but if present is of considerable technical difficulty in putting the RV lead in RV. With proper technique, successful CRTD device implantation can be done. And LV lead placement is easy if the vein is there. So case third is again the classical indication for CRTD, but the access vein is blocked. I'm a peripheral angioplaster also, so crossed it, dilated with the a 6 millimeter balloon, put all the wire, and then selectively hooked there is a stenosis in the posterolateral vein. And then that vein I crossed with the balloon, and then your subselect seat, and then the lead was put, quadripolar lead was put, and then the CRTD implantation was done. And you can use the different subselect, 130 degree, 90 degree, or obtuse, depending on the anatomy of the origin of the tributaries. So success CRT implantation depend on coronary sinus anatomy and left subclavian vein access. Venoplasty of brachiocephalic vein and CS tributaries and subselect catheter help in difficult anatomy. This patient has remarkable recovery. Case 4 is DCM, again class ejection fraction 30%. Classical indication for CRT implantation. Here CRTP was selected to put CRT because there was no scar in the MRI. And this is the vein where we wanted to put just slightly bear with us. This is the vein where I wanted to put the lead, but the problem was different. Problem was the lead we put very easy.